we're going to move on to another topic in this session. So this topic will be presented by Dr. Fairuz Kabinawa. Dr. Fairuz now in the United States, and he's going to call in to give us a talk through the webcast. So before we start, I'd like to introduce him. So Dr. Kabinawa, he's a medical oncologist. He finished his fellowship at UCLA, and now he is the principal medical director at Genentech. And he's gonna give us the talk in the topic of why and what to combine with cancer immunotherapy. So, Dr. Kabinawa. Okay.
Can you guys hear me?
Yeah, we hear you. Okay, so please welcome Dr. Kabinawa.
Can you hear me now, please?
Yes, we hear you. Go ahead.
Okay. Thank you all for inviting me to this seminar on cancer immunotherapy. And so good morning to all of you. It's evening time in San Francisco. So my talk is going to cover rationale. What is there any logic for immunotherapy combinations? So you have heard this, you have seen this slide before. Can you also see me on there? So you have seen the slide. The key features, this is cancer immunotherapy cycle. And I'll show you if you look at the, this is the tumor, and the tumors carry a lot of antigens. And then when they release the antigens, when they die, when they're dividing, when they're multiplying, these cancer antigens are taken over by the dendritic cells. The dendritic cells then take it to the T cells. The T cells are now primed and activated. So number 4. And the next step is moving the T cells into the tumor. That's the trafficking part. And once they enter back into the tumor, the T cells now start recognizing those cancer cells that have that specific antigen, and the cancer killing of the cancer cell occurs. There are 2 important players in this one, the PD-L1, which is the protein or the ligand. The PD-1 is the receptor. And their interaction is the rate-limiting step in the anti-cancer immune response. And that's what we are going to try and see how we can reverse it. So PD-L1 expression prevents T cell priming and activation in the lymph node. And then PD-L1 expression leads to inhibition of anti-cancer tumor cell T cell activity in the tumor microenvironment. So again, two players I wanted to remember, PD-1, PD-L1, and then we'll cover some of the other players that have been identified now. So you heard from the previous speaker that the cancer has a different phenotype. You also know by now that even in patients with intact immune system, only about 20, maybe 30% of patients respond. The remaining patients do not. So why don't they respond? Why only a quarter to 1/3 of the patients respond? So what we have figured out is that some tumors have pre-existing immunity, what's called as an inflamed tumor. There's a lot of infiltration of the T cells into the tumor bed. However, the T cells by themselves cannot target the cancer or kill the cancer because of the PD-L1 and PD-1 interaction. It acts like the brakes in your car. When PD-L1 binds to PD-1, even though your car is on, it looks like someone has pushed the brakes down. And so the car, though turned on, is not able to move forward. And so if you look at the second phenotype in the middle, it's there's a T cell migration defect, meaning there's a tumor, and around it, there's maybe fibrosis, maybe fibrous tissue, maybe something that is not allowing the T cells to enter into the tumor bed. So there's a barrier there. So we need the T cells to infiltrate the tumor. These are excluded from immune cells, T cell migration defect. And the third phenotype is there is no pre-existing immunity. The tumor cells just don't have any lymphocytes in them. So here, the issue is we may have to generate active tumor-directed T cells and get them to move into the tumor bed. So there's a continuum. It's not like it's one is this and one is this, one is this. Of course there are, but there's a tumor immunity continuum that provides a framework for rational development of therapy. So where there is an inflamed tumor, there's a mutational load, and so all we have to do is take away the checkpoints, so PD-L1 inhibition or PD-1 inhibition, and the lymphocytes will do the job. Here, we have to make sure in the second one, where the immune excluded, we have to make sure that we get the T cells to infiltrate the tumor bed. And we'll talk about some of the therapies that are directed at it. And then here in the third part, we have to get T cells to move into the tumor bed. So we talked about that, exploring the synergistic potential of targeting PD-L1 and other pathways in rational combinations. And by understanding these mechanisms of immune escape, we can then start thinking about how we can bypass the escape routes or block the escape routes and then generate T cell activity required for the patients. In the inflamed tumors, combination approaches that target PD-L1 and other complementary pathways may provide us a synergistic pathway. In the immune desert, in immune excluded, we need to, like I said, we have to come up with mechanisms that allow the T cells to infiltrate into the tumor microenvironment. Now, one of the things that we have done is we have combined anti-PD-L1 drugs or anti-PD-1 drugs with chemotherapy. So what's the rationale behind it? So when you give chemotherapy, as you can see here, the chemotherapy, and you're going to kill a fair number of tumor cells, and fair number of tumor cells will be injured. So what happens when that occurs? There's a release of tumor antigens, and these tumor antigens are then carried over by the dendritic cells, as you can see here. Here's the tumor antigens being released, and then the dendritic cells carried it to the lymphocytes and so on and so forth. And so chemotherapy elicits an immunostimulatory effect to promote anti-tumor activity. It promotes recruitment of dendritic cells to the site of cell death, where a lot of tumor antigens are floating. And then these T cells, the antigens are carried to the T cells, where it leads to T cell activation. Additionally, the chemotherapy induced immunostimulatory effect may promote anti-tumor activity, also secondary effects, by decreasing the number of myeloid-derived suppressor cells, MDSCs, and T regulatory cells, which essentially have immunosuppressive function. So when the immunosuppressive function is lost, the immune cells can then be activated. So there's a multi-effect from chemotherapy that potentiates the effect of immunotherapy. So a combination of rationale for combining cancer immunotherapy with chemotherapy. The combination of immune checkpoint inhibitors and chemotherapy, we already agreed, may be synergistic. And we now, rather than going through all these details, we now have evidence. I think it's on the next slide. No, it's not on there. We now have evidence that PD-L1, anti-PD-L1 approaches with atezolizumab with chemotherapy has shown to be active in non-small cell lung cancer. The IMpower 150 study, IMpower 132 study. And so there is now clinical data that has been generated that there is synergy between chemotherapy and anti-PD-L1 approaches. Same thing you have seen with Pembro in the 189 study, you've seen with Nivo. So there are multiple studies now that showing that combining chemotherapy and checkpoint inhibitor therapy has a clinical benefit. Checkpoint inhibitor combinations, cancer antigen presentation, vaccines, anti-CD40 agonists. So here's the tumor cells produce antigens, and that can be recognized. We know that. Tumor-associated antigens are expressed by tumor cells and recognized as foreign antigens by the host, by the patient's immune system. New antigens, again, those are tumor-specific antigens that arise during tumorigenesis. Antigens are bound to the major histocompatibility MHC molecules and presented as a combination of MHC peptide complexes, which are then recognized by your T cells. And This is what you see here, dendritic cells. And then they're transported to the lymphocytes, lymph nodes. Dendritic cells present the T cells to the, an activation program is initiated. And the T cells are now ready to go and target the tumor. Immune responses to tumor antigens can be enhanced, theoretically at least, by using therapeutic cancer vaccines. So what do the cancer vaccines do? Cancer vaccines target patients' own immune response. So think about what the immunization occurs. We give immunization to children, and they develop a whatever it may be, anti-diphtheria, anti-polio, antibodies, and those in turn strengthen the patient's own immune response to subsequent attack by these antigens. While dendritic cells can be generated by loading tumors. So all these things that you see on this slide are essentially ways of providing new antigens, taking the new antigens, tumor-associated antigens, to the host T cells. And there they get primed, and then they go back and target the tumor. So dendritic cells, which are loaded with tumor-associated antigens, they are treated with adjuvants so they can multiply and develop an immunity. These dendritic cells then are administered back into patients to induce anti-tumor immunity. Protein peptide-based vaccines, DNA vaccines, RNA vaccines, and viral-based vaccines. Variety of ways. The goal here is to get the antigens to the T cells. Think about it this way, that you have a police force in your city or in your country, and you're training them to recognize the enemy. And that's what we are trying to do. We have T cells in our body, and we need mechanisms to influence the T cells, to retrain them, reprogram them, to think of tumor or tumor-associated antigens as targets. So personalized cancer vaccine is something that is being discussed and developed by multiple pharmaceutical companies, including mine. So PCVs, as they are known, are individualized therapeutic vaccines targeting neoantigens that are specifically expressed in the patient's own cancer. So it's unique to that patient's tumor. As neoantigen expression is tumor-specific, immunotherapeutic targeting of such non-self antigens should potentially be safe. Immunogenic neopeptides are selected for each patient using next-gen sequencing and computational methods. So what are these? How does it work? PCV, you will take a single-stranded mRNA targeting up to having about 20 neoantigens, which is then taken up by the dendritic cells, leading to immune stimulation and antigen presentation. Or the peptide, which are, again, targeting up to 20 antigens, the same thing. This is then injected back in the patient, leading to T-cell dependent immune response with high tumor specificity. So that's the science behind it. Again, as I've said before, the goal here is to take an antigen and show it to the T cell. How best we can do it, there are a variety of ways that people are doing it. So PD-1 blockade combined with viral-based vaccine can enhance systemic anti-tumor cells, tumor response by enhancing the recognition and killing of tumor cells by T cells that have been primed by the vaccine. Again, as you can see, the vaccine in and of itself has to work with the T cell. So it goes to the T cells and says, hey, listen, here are the tumor antigens. The T cell recognizes it. Now, PD-1 blockade, you have reversed that. So the T cell is now active. It is primed by the vaccine, and hopefully this will have a synergistic effect. What about checkpoint inhibitor combinations? Activating the T cells from multiple sites. So here there are multiple ways you can do it using an agonist, or you can use an anti-CTLA-4. So let's talk a little bit about anti-CTLA-4. The CTLA-4, cytotoxic T lymphocyte is a co-inhibitory transmembrane protein expressed by activated T cells, which binds to B7-1 and B7-2 molecules on the antigen presenting cell, blocking T cell activation. So when this is bound, the T cell is not active. CTLA-4 is a CD20 homolog. However, CD28 B7 binding produces stimulatory effect, as you can see on this upper right-hand corner. So when the CD28, which is a homolog for CTLA4, when it binds to B71, the T cell is activated. However, when CTLA4, when it binds to the B71 receptor, and it leads to a reduced T cell proliferation and survival. It's a CTLA4 co-inhibitory receptor. So it's a reduced information. So when you block the CTLA4, you're taking again the brakes off. As the CTLA4 plays a role in blocking T cell activation, anti-CTLA4 antibodies may allow the activation and proliferation of more T cell clones and reduce the Treg-mediated immune suppression. And both preclinical and clinical data suggest that CTLA4 blockade results in activation of CD4 and CD8 T cells. CTLA4 blockade in patient has been reported to diversify peripheral T cell pool. Now, this approach is essentially taking the brakes of the T cells through the CTLA4 mechanism. PD-L1 and a PD-1 blockade is a different mechanism where we activate the the T cells. So now we are combining together. So you are activating the T cells from multiple places. So anti-PD-L1, anti-PD-1, or anti-PD-1 plus anti-CTLA4, blockade of PD-L1 or PD-1 pathway restores activity of anti-tumor cells that have become quiet, that were quiescent. Combining CTLA4 inhibition with PD-L1 inhibition could have a synergistic effect, resulting in a larger anti-tumor response. And then you have clinical data that suggests that this combination has merit in melanoma, in kidney cancer, and some other tumors that have been tested. However, you have also seen that this double activation of the T cells has also resulted in slightly higher immune-related side effects. Now, killing of the cancer cells with the anti-PD-L1, anti-PD-1, immunocytokines. Now, let's talk a little bit about immunocytokines. Immunocytokines are antibody cytokine fusion proteins which are able to preferentially target tumors and to activate the immune system locally at the site of the disease. Cytokines, as you know, are chemicals that can activate or inhibit activity of the immune system. Pro-inflammatory, meaning those that activate the immune system, we all know the interleukins, IL-2, IL-12, TNF. They have been developed and are being evaluated in clinical trials. IL-2, we think, plays a significant role in the proliferation of CD4, CD8 positive T cells, B cells, and natural killer cells. People who treat kidney cancer, I used to be one of the kidney cancer doctors when I was at UCLA. I treated a lot of patients with high-dose IL-2, taking advantage of its immunostimulatory properties. IL-12 stimulates the production of interferon gamma by T cells and stimulates natural killer and T cell effector functions. So another way of stimulating T cells. Again, remember the goal here is to make the T cells more active, improve the number of T cells, activate them, and also tell them or reprogram them or program them to go after the tumor cells. So the variety of immunocytokine combinations have been developed. FAP-IL2 with IL-2 variant. So fibrogen-associated or fibroblast-associated protein with IL-2 variant combination. So the antibody is anti-IL-2. So here the rationale is those tumors that have FAP or fibrous tumors, the antibody would be pulled into there, and there the IL-2 will be cleaved, and IL-2 will now be released into the tumor microenvironment and have a local anti-tumor effect. You have L19-IL2 combination, L19-TNF combination, variety of ways, and you can see here, here's the cytokine on the tail of the antibody, and it's cleaved off. When it enters into the tumor bed, the antibody will take it to where the tumor is, and the cytokine will be cleaved off, and you will have a local effect so that you minimize systemic side effects. Well, that's the science behind it. So here are some of the combinations that are being done. Different cytokines may activate or inhibit different subsets of leukocytes. most pro-inflammatory cytokines, including IL-2, TNF, mediate and the influx of leukocytes in the site of disease. We all know that the given IL-2, especially in kidney cancer, you will have a lot of T cells moving into the tumor bed. PD-L1, PD-1 inhibition, as I told you, will take the brakes of the T cells and allow them to be activated and then move into the tumor for tumor killing. The combination of both, we think, may lead to enhanced tumor cell kill. And so these are some of the studies that are in the early stages of clinical development. So we talked a little bit about infiltration of T cells into the tumors. So here's there are barriers, and the T cells cannot cross that barrier to move into the tumor cells. So we'll talk a little bit about anti-VEGF agents. So what does vascular endothelial growth factor pathway do? It is the most important inducer of angiogenesis. We have now worked on it for last 20 years. We have huge amount of clinical data in lung, colorectal, breast, kidney, and you name it, and ovarian cancer, a variety of tumors. So angiogenesis is now our anti-angiogenic approaches to tumor, to cancer treatment is a part of our clinical practice. The VEGF is a multifunctional cytokine that stimulates vascular endothelial cell growth, survival, proliferation. It also plays a role in vasculogenesis formation, new blood vessel formation, and angiogenesis, blood vessel remodeling, and expansion number of ways. So you have all these things. The things that we should look into are this. It increases vascular permeability, so the blood vessels are leaky, allows the endothelial cell migration, invasion, and also T cell moving to the tumor bed. So here's what VEGF, vascular endothelial VEGF does. It impairs dendritic cell maturation, so resulting in reduced T cell priming. So it has an anti-T cell effect. VEGF also promotes formation of dysregulated tumor neovasculature, which hinders T cell infiltration and triggers T cell death. VEGF stimulates expansion of myeloid depressor cells and then Tregs, resulting in immunosuppressive tumor microenvironment and thus having a dampened anti-cancer effect. So what if we block VEGF? What are the things that might happen? So here's what will happen. When you block VEGF, it will lead to dendritic cell maturation. So dendritic cells can then take the tumor antigens and get it to the T cells. And then I've been asked to wrap up very quickly. So normalization, reprogramming. So you see these effects that you happen here. So you have some clinical evidence for the combination in IMpower 130. So Atezo, Bev, and first-line normal NS non-small cell lung cancer. You have Atezo plus Bev plus chemotherapy, and you can see a hazard ratio of 0.78 and a improvement from 14.7 months PFS to, overall survival to 19.2 months. And same thing, you can see an advantage in the PFS as well, with an impressive hazard ratio of 0.62 with the 4-drug combination, including chemo, Bev plus Atezo. We have similarly a synergistic effect with Atezo and Bev in MRCC, and I'm not going to go into the details in the interest of time. And in hepatocellular carcinoma, very, very impressive data. As you can see from the spider plot, majority of the patients having a response, and some of them really having durable responses. So there's a clinical evidence now that the combination of Bev Atezo makes sense. And this is a huge, impressive clinical development plan for Atezo. I'll share that with you here in another slide here. So next generation cancer immunotherapy, very quickly. We have a combination of an antibody, bispecific antibody that targets CEA and CD3, that's on the T cells. So this is being tested in CEA-producing tumors, going through a phase 1 and 1B testing. We have CD20, CD3 bispecific antibody that is also being tested. FAP-IL2 I talked to you about, and then the personalized vaccine. And then you have activity for the CEA-TCB bispecific antibody, we have it in colon cancer and some patients. And then you have the personalized cancer vaccine data that is now generating clinical efficacy data in melanoma and other tumors. You saw this slide, variety of ways that you can target some of the immune system blockages so you can have a better therapeutic index. Inflamed tumors, immune excluded, immune desert. So a multi-pronged effect, multi-pronged research that is being done. So this is an impressive clinical program for Atezo, you can see. This is being done in ovarian cancer. Here's non-small cell lung cancer. Here's kidney, prostate, and bladder. You have colorectal cancer. You have combination therapy. And then we also have studies going on in head and neck cancer, and hematology. So a very comprehensive development program for immunotherapy in my company. So what is the future hold? What do we think? We have now done the cancer inhibitor monotherapy studies. We are now combining with the existing therapies, chemo, BEV, targeted therapy. So we have an improving therapeutic index. And then we are looking to expand beyond checkpoint inhibitors, double immunocombinations, multiple combinations targeted at diagnostic positive subgroups, the personalized checkpoint inhibitor therapy, and so on and so forth. So again, immunotherapy at the moment has shown promise in about 20-30% of the patients, but we think there's a lot more to be done with this approach. So I'm going to stop here, and thank you all for your time and attention, and I hope the audio and video was up to you par so that you could see and hear, see my slides and hear my voice, and I will stop here. Thank you all very much.
Thank you. Thank you very much, Dr. Farooz. So I think we can have one or two questions. Anybody like to have some question? So Dr. Farooz is still with us, right? Are you still?
Yes, I am.
Yeah. Okay.
I'm here for the next few minutes because I have some other engagements that I have to be at, so I'll be here for the next 5 minutes to answer your questions.
Okay, I have one question for you. So.
Yes, sir.
Based on that, you already show us the tumor immune phenotype. So probably we might be able to keep the different cancer immunotherapy for each immune phenotype. But the direction now for the combination IO, it seems to be for the all-comer. So how do you think that could we have anything to help us to more personalized in terms of cancer immunotherapy based on your suggest of the tumor immune phenotype?
So very good question. At the moment, as you may know, that there are two biomarkers that people are using, PD-L1 status and the tumor mutational burden. Both are imperfect biomarkers. In some studies, PD-L1 appears to, especially with the Merck studies where more than 50% of patients or 50% CPS combined positive score, they tend to do well, but they also less than 49% also do well. So so it doesn't help us select only those patients that would benefit. There are a lot of patients who benefit. From most of our studies, even patients that had PD-L1 scores of low scores also benefited. So at the moment, I would like to say that it is not a perfect selection marker. TMB also, the tumor mutational burden, we're also trying to fine-tune it. So what do we do with these things? So we know that there are patients who respond, so they are primary responders. There's a group of patients who are primary failures, who do not respond at all. And then there's another group of patients who respond and then fail. So those would be the secondary failures. So the question we have to address is, how do we, select patients who are likely to respond right away? But more important question is, how do we treat those patients that do not respond primarily? So there is where the combinations of chemotherapy, chemo BEV or chemo anti-angiogenic plus checkpoint inhibitors or double chemo or immuno combination that are being studied. Can we look at their phenotype and decide? At the moment, that has not been clarified. I mean, we don't necessarily look at the pathology report and say, well, there's no lymphatic infiltration. Maybe that's an immune desert. Maybe we should do something different for this patient. Or we say a patient has a lot of lymphocyte infiltration in the tumor. We don't say, well, let's go and treat that patient. We are not at that stage yet. So the search for better predictive markers is still going on. Search for better patient selection is still going on. Having said all that, we do still use you have the Merck data where this is extremely important. In our studies, it appears to be all comers who benefit. So there is a gradient. Patients who in the IMpower 150, patients who had overexpression or high expression, their magnitude of benefit was high. But the patients who had low expression, they were not, their response was not zero. They also enjoyed a benefit of the immunotherapy drug. So we don't, it's a debate that will continue until we have a lot more research that requires to be done. A long answer to a very important question.
Okay. So I think that we are a little bit scheduled behind. So
yes.
So thank you very much, Dr. Fairuz, and thank you, Ajahn Ekaprop, for the excellent talks. And so I'd like to close the section. Thank you.